Okay, good morning, everyone. Why don't we get started? It's a pleasure to welcome you back to our Grand Round series. And this morning, I have the distinct pleasure of introducing Dr. George Nasrallah, who is one of the newest faculty members at the University of Toronto. He's an oculoplastic surgeon based full-time out of the Mount Sinai Hospital, where he's been just a real dynamo for the residents. I do think he's been a real asset both to the department, to Mount Sinai Hospital, but especially to our residency program, as well as the Oculoplastics Fellowship Program, where he's now one of the attendings, and I believe the coordinator of that fellowship as well. So, George, thank you for everything you've been doing. Welcome this morning. I should point out your academic history. So we won't hold it against him that he completed his residency at McGill, because he did come to his senses and complete his fellowship at the University of Toronto in oculoplastics. After which he was recruited to come on staff on faculty and Mount Sinai Hospital, as I mentioned. So, George, thank you for doing grand rounds this morning. Mohammed and Brian, great to see you guys, and I look forward to your talks.
Thanks, Amity. Appreciate the warm introduction. So the plan for the ground rounds today, we're presenting a couple of topics. The first one that Brian will present is a very atypical presentation and manifestation of a relatively common condition. And then Mohammed will talk about an important topic. I don't think we've talked about it probably enough in the last few years. It's revisiting a topic we're all familiar with that I think I just wanted to give an updated kind of oculoplastic perspective on it. So without further ado, Brian, you can go ahead and start with your presentation.
Okay, sounds good. Can everybody see my screen and hear me okay?
Yep, looks good, sounds good.
Okay, great. Thank you. Okay, good morning, everyone. My name's Brian Wong. I'm one of the third-year ophthalmology residents here at the U of T program. And today I'm excited to talk to you about a case of atypical orbital cellulitis in a pediatric patient. As you know, my supervisor for this grand rounds is Dr. George Nasrallah, and I also want to thank Dr. Kenneth Chang, the oculoplastics fellow, for his guidance with this case as well. And I have no conflicts of interest to disclose. Our objective for this grand rounds is one, to review the management of orbital cellulitis in pediatrics patients. Two, to discuss an atypical case of orbital infection. Three, to recognize the various serious complications of orbital cellulitis. And fourth, to review the orbital anatomy and its relation to complications of orbital cellulitis. So our case is about a 3-year-old boy, generally healthy, and he was referred to us by the Sick Kids Emerge for a red, swollen, and proptotic eye in his right eye for over 9 days. This was in the context of fever, irritability, and upper respiratory tract symptoms for over 3 weeks. Him and his family were from up north, so they presented to 2 hospitals north of the GTA over these past 3 weeks, and they were given various diagnoses, including a viral illness and bacterial infection, and for which they were given various antimicrobial treatments, including one dose of IV antibiotics and PO antibiotics. He got Keflex for over 10 days. Throughout this time, the swelling in the right eyelid mildly improved, but he still had fever and vomiting persisting, and that's why he was brought to Sick Kids Emerge. On examination, it was a difficult exam because the child was quite irritable and quite in distress. So some of the exam results are limited, but the visual acuity was central, steady, and maintained in both eyes. The eye pressure was soft and equal to palpation in both eyes. Pupils were normal, equal, round, and reactive, and there was no RIPD in either eye. Extraocular motilities were normal as well, full and symmetrical in both eyes. And on external exam, there was mild right upper lid edema and erythema. There was a question of whether there was mild proptosis. Some of the emergency doctors picked it up. On my exam, it was kind of hard to tell, maybe pretty subtle, but the rest of the anterior segment exam was normal in both eyes. And the dilated fundus exam, although limited, was normal from what we could see initially. So no signs of optic nerve or retinal involvement. And these are pictures of the real case. They were taken and used in this presentation with consent from the picture's mom. So you can see that the right eyelid there, the upper lid looks a little swollen and a little red. So based on our exam, given the clinical picture of full extraocular movements, no RIPD, and no optic disc edema, the exam seems more consistent with preseptal cellulitis. But because there was some possible proptosis, and given the boy's systemic symptoms like being febrile and lethargic, we decided to order a CT scan. to rule out any possible orbital cellulitis and any CNS involvement. Also, with help from infectious diseases, we decided to treat him with 3 IV antibiotics, cloxacillin, metronidazole, and ceftriaxone. And we consulted general pediatrics to admit them for monitoring. So on one-day follow-up on the ward, he continued to be irritable and crying. His mom was concerned that he was feeling worse, and she thought that his eyelid seemed to be more swollen, and he continued to be febrile. On examination, it was mostly unchanged. The VA was still central steady and maintained in both eyes. Pupils were still normal. Extraocular motilities were still full in both eyes. But when we looked at the right eye again today, we saw that there was more eyelid edema and erythema. The eyelid looked more tense than yesterday. Still hard to appreciate any obvious proptosis, though. And so previously, the first night, we had attempted a CT orbits, but the patient was quite irritable and uncooperative. So we plan to do a CT again, but under GA sedation. And this is what the CT shows. This is a coronal cut of the CT. And then here is a video of the scroll through as well. And can any of the residents speak up and tell me what they see on the CT scan?
Brian, maybe we can get one of our senior residents to answer this.
Yeah, sure. Anybody's welcome to speak up.
So it went by pretty quickly, but I thought I saw like a superior maybe fluid collection, like supranasal. And the globe was pushed infratemporal, like displaced.
Yeah, that's good. Yeah, so exactly. So what the CT report showed was that there was a right-sided orbital cellulitis. You could see some inflammatory, just kind of generalized material there. There was an intracoronal abscess, and this did stretch from the superior temporal side to the superior nasal side, the area that I think Sheikha pointed out. And this abscess measured 1.4 by 2.2 by 1.3 centimeters. It also noted a cavernous sinus thrombosis, which involved the superior ophthalmic vein and also the internal jugular vein. Of note, there was no associated paranasal sinusitis, and this was unusual because most cases of orbital cellulitis are associated with some kind of sinusitis. Incidentally, there was also opacification of the mastoid and the middle ear.
Brian, I'm just gonna make a quick comment.
Yep.
It's that I totally agree that yeah, there's an abscess or a possible fluid collection in the orbit, but the CT scan is not necessarily always the best at accurately defining the collection, and oftentimes you'll have to do an MRI with different phases and diffusion weighted imaging to get a better sense of exactly where that collection is, because there's a lot of fat stranding and whatnot that muddies the picture. Sometimes you can go in thinking you're going to get an abscess and you won't. So that's the other little caveat.
Yeah, exactly. So given this, we saw a lot of inflammatory material in that right orbit. So we were planning to do an MRI along with like a sedated exam so we can better characterize where that abscess is. And so, but before we do that, let's just review the definition of orbital cellulitis. So it's an infectious inflammatory process which involves the soft muscles in the orbit posterior to the orbital septum. And this is different from preorbital or preseptal cellulitis, which has an infectious inflammatory process anterior to the septum. And signs of orbital cellulitis include eyelid erythema and edema, proptosis, conjunctival chemosis, reduced visual acuity, extraocular motility limitations, RAPD, increased IOP, resistance to retropulsion, and fever. Symptoms that a patient may report include vision loss, double vision, pain with eye movement, headaches, and lethargy. And as you all know, orbital cellulitis is a very emergent condition and needs emergent treatment, or else it has vision and life-threatening complications.
Also a quick comment, Brian, about just go back once, just so that the junior residents know, the picture is just an illustration, a schematic. Most of the time you have orbital cellulitis, you'll also have swelling and redness of the preseptal tissues as well. So it's never just it's rarely ever just in the orbit. So don't be kind of fooled by the schematic.
Yeah, thanks, Dr. Masrella. And then Moving on, there is a classification of complications of orbital infections as well. And this was coined by Dr. James Chandler, who is an ENT surgeon from Florida. So the Chandler 1 classification shows preseptal cellulitis. And this picture on the right is from Radiopedia, illustrates them pretty well. So type 1 shows inflammation and edema anterior to the orbital septum. Chandler 2 is an orbital cellulitis, which shows inflammation and edema extending posterior to the orbital septum inside the orbit here. And 3 is a subperiosteal abscess, which is collection of pus and infectious material beneath the periosteum in the bony orbit. And most often this is around the lamina capricia, which is a thin part of bone between the orbit and the sinuses. 4th is an orbital abscess, which is a collection of purulent material inside the orbit itself, not just underneath the periosteum. And a Chandler 5 is the most serious complication, is cavernous sinus thrombosis, where you have retrograde phlebitis of the infection into the cavernous sinus posterior to the orbital apex. And whenever you have a case with progressive proptosis, globe displacement, or a lack of response to antibiotics for an orbital cellulitis, you would be concerned about abscess formation. And this can be identified on CT orbits. But like Dr. Nasrallah said, an MRI would be better, will show better resolution of any possible abscesses. So in the case of our child here, based on the CT scan, we have
sorry, Brian, I'll just, and the caveat is that that's mostly important in kind of atypical cases. If it's a typical case of sinusitis with an abscess, then you can probably be sure. But in atypical cases where you're not sure, you're better off getting the MRI.
Right. And in our case here, based on the CT scan, we have a Chandler 2, 4, and 5. And there are also 4 main types of different causes for orbital cellulitis. The first type of cause is periorbital extension. And the vast majority of orbital cellulitis cases come from paranasal sinuses or the sinusitis. And depending on what study you read, some groups say up to 90 to 95% of orbital cellulitis cases originate from a sinusitis. Other causes of periorbital extension include face and the eyelids, and this would be deeper in the eyelid tissue. Lacrimal sac infection, like a dacryocystitis, or a dental infection. Another type of cause of orbital cellulitis is exogenous causes. So this includes trauma and intra-orbital foreign bodies, as well as surgery or iatrogenic cases. A third type of cause is endogenous causes for orbital cellulitis, and this can come from bacteremia or a systemic blood infection with septic embolization of like an embolus into the vasculature in the orbit. And 4th is intraorbital causes, and these can be endophthalmitis or dacryoadenitis or infection of the lacrimal gland. And so looking at our case again, since our child doesn't have any sinusitis, he doesn't have any dacryocystitis, dental infection, or any previous trauma or surgeries, we can see that our case is an extremely rare case. And a very important point from all this is whenever you're presented with a case of suspected orbital cellulitis, it's important to order orbital imaging to look for any potential sinusitis, abscesses, or foreign bodies. And on 2-day follow-up, the child was still irritable and photophobic. Swelling was worse than the night of admission. And the thrombosis team had actually started him on heparin overnight for the cavernous sinus thrombosis. And on examination, the vision, pressure, and pupils were still normal, but now there was obvious limitations in supraduction and adduction of the right eye. And the eyelid edema, erythema, and proptosis also worsened from the day before. You can see that the upper lid there looks pretty tense. Also, there was noted to be a pink mass on the superior temporal conjunctiva in this right eye, and I pointed out with the red arrow here. And this is likely the lacrimal gland. And the kid also had 2+ SPK as well. On dilated fundus exam, when the child was sedated, his optic nerves and the retina continued to be normal, no disc edema, and the rest of the posterior segment was normal. So with this part of the assessment, there are a few points to keep in mind here. With his extraocular motility limitation, there's a question of whether this was due to orbital inflammation itself, causing swelling of the structures inside the orbit and a physical limitation of eye movements, or whether it could be from the cavernous sinus thrombosis affecting the cranial nerve 6. So at this point, it's really hard to tell which one or possibly both could be causing it. The second important point is often whenever you have a source of inflammation in the orbit, the lacrimal gland can also be secondarily affected. But this doesn't always necessarily mean that it's a primary lacrimal gland pathology, like a dacryoadenitis. So at this point, what do we think of this case? So while the clinical picture is still most suspicious for an orbital cellulitis, since the globe was generally white and quiet, different from your typical orbital cellulitis cases, and because the kid wasn't improving clinically despite 2 days of antibiotics, we took a step back and tried to keep in mind a broader differential of orbital pathology. So this is a list that could be considered if you ever have an atypical case of orbital cellulitis. So differentials for orbital pathology can include orbital cellulitis or dacryoadenitis. Sometimes it can be inflammatory causes, like sarcoidosis, can come with bilateral orbital, especially lacrimal gland inflammation. You can have TB that causes this as well, and possibly thyroid eye disease, although in our case, given the clinical history, it was pretty unlikely. You can also have non-specific orbital inflammation or idiopathic orbital inflammatory syndrome as well. And this is usually bilateral, and it would be a diagnosis of exclusion. You can have vascular causes like orbital venous or AV malformations. You could have benign neoplasias, such as lymphatic malformations or lymphangiomas. And a lymphangioma can form quite quickly as well. So this could potentially be consistent with the child's orbital swelling and proptosis here. You could also have a hemangioma, which would be unlikely because they tend to form a little slower. And for malignant neoplasias, there can be a variety of them, which can cause proptosis quite quickly, which could potentially be consistent with this clinical presentation too. So you could have rhabdomyosarcoma, leukemias, and metastases like neuroblastomas, which can also come pretty quick. So what we thought for a patient was, despite this white and quiet eye in the picture of proptosis and his lack of improvement on antibiotics and still being febrile, we thought it was most likely to be an infectious cause, but we still wanted to rule any other possible inflammatory causes. So we did inflammatory blood work, including ACE, IgG4, ANA, CNP-ANCA, QuantiFERON Gold, TSH, and syphilis serology. We continued his 3 IV antibiotics, and there were also considerations of whether to start any systemic steroids with this kid. And this could probably help with the inflammation, but it was also quite controversial as it could make any active infection worse. So we'll discuss this more in the next slide. But the most important thing was that we would continue monitoring this patient closely twice a day and keeping a low threshold for surgical drainage if he continued to deteriorate. So more on the steroid use in orbital cellulitis. Like I said, it was kind of controversial because sometimes it can make infections worse. But the reasoning behind using systemic steroids in orbital cellulitis is twofold. For a cellulitis that comes from a sinusitis, it's thought that steroids could decrease inflammation and swelling in the orbit. And it can concurrently help with sinus drainage by reducing sinusitis and reducing the amount of swelling in the ostia where normally the sinuses drain. And in a lot of cases of orbital cellulitis, several different studies have found that children receiving adjuvant steroid therapy have shorter hospitalizations or a shorter course of symptoms. However, this wasn't the consensus for all cases. And there are limitations in these studies because of randomization issues. And the metric of hospitalization length was also not perfect because of confounding factors like differing practice patterns for doctors and discharge logistics, depending on the country or the hospital. And there was also no clear consensus in the timing of administration, dosage, or the route of administration for systemic steroids. So further clinical trials are needed to see if evidence really supports this. But for our case here, since our child doesn't have any clinically significant sinusitis, this use of steroids applies even less to our case. And so at this point, we did an MRI of the brain and orbits for the child. And can any of the residents tell me what they see in these 2 scans?
Anybody? Ron?
No, that's okay.
Yep.
Keep going. Yeah, so
And
these
you
are MRI. These are MRI T1 scans, axial cuts. And the left picture shows the part of the abscess. So this shows the lateral part of the abscess. And like we said earlier, the abscess was shaped in a V, and the point of the V was pointing posteriorly and just inferior to the superior rectus. And then the two arms of the V go temporal and nasal. So earlier when Sheikha described the first part, that was a nasal arm, and this part that the arrow is pointing to is the temporal arm of the abscess. And then the right picture here shows thrombosis of the superior ophthalmic vein. So you can kind of see this little arc-like structure there, and that's just a thrombosed vein there. And in addition to the thrombosis of the SOV and the cavernous sinus, the MRI report also notes the thrombus extending inferiorly to the right inferior petrosal sinus, as well as the internal jugular vein. Incidentally, there was also enhancement seen in the internal acoustic canal, the cochlea, and the semicircular canals on the same side, and this suggests labyrinthitis. So this is just a scroll through of the MRI. This is a coronal T2 scan. And you can see posterior to the globe, the hyper enhancement there, those two areas that kind of converge, shows that V-shaped abscess. And I'll go through it again for you guys. And it shows that it's multilobulated within the intraconal space.
And Brian, could you point out the cavernous sinus thrombosis?
Yes. Here, it might be a little harder to see, but it would be that really thin part there, like medial to that, the medial arm of that abscess. That's Dr. Nasrallah may have a
So,
better.
so for the cavernous sinus component, usually I'll scroll back. I mean, first of all, it's hard for me to see because I don't usually look for them, but it's usually you scroll back to the level of where the chiasm is, and that's around the area where you'll have your pituitary gland, the clinoids, and you know that the cavernous sinus is around that area. So you'll see kind of asymmetry and fullness and whatnot of the cavernous sinus. This one doesn't go, I think, posterior enough to see it quite well.
Yep.
But that's usually where it is. I honestly usually rely on the radiologists kind of making that call. But for the orbital components, kind of where I put my focus on. But I think this may be a bit too anterior to see it.
Yeah, that's true. And sorry, the part that I meant to point out was I think this superior orbital vein thrombosis, which is just that little part there, and that would lead to the cavernous sinus. But yeah, this doesn't go far enough back. So as an aside, we can talk about subperiosteal abscesses as well, because it's a more common complication of orbital cellulitis, although we didn't have any in our case. So there is a list of several criteria where you would choose to surgically drain a subperiosteal abscess in a case of orbital cellulitis. And these are called the Harris-Garcia criteria, and it's named after two oculoplastic surgeons from Wisconsin. And so the first two indications here are indications for drainage for patients of any age with SPA, and they include evidence of optic nerve compromise, like an RAPD, or an enlarging SPA. And also, if the SPA doesn't resolve within 3 days of antibiotic administration, you would think to drain it as well. Other indications in these criteria include if the patient was 9 years old or older, if they have a frontal sinusitis, if there's a non-medial SPA location or an intraconal abscess, if the abscess is large, or if there's a suspected anaerobic infection, like if you see gas in the abscess on the CT. Also, you would consider draining in an SPA if it recurred after a previous drainage. If there's evidence of chronic sinusitis, like nasal polyps, acute optic nerve or retinal compromise, seen through a dilated eye exam, or if there's an infection of a dental origin.
A couple of points about this slide, Brian, is
Yeah.
that first of all, the Garcia-Harris criteria was based off of a relatively limited number of patients, and it was specifically looking at sinus kind of origin orbital cellulitis. So that's one caveat. The other one is the point of this criteria is to try to identify patients who are not going to improve with medical management, and that's what precipitates surgical management. And so you know, the application of this is relatively controversial because for most of these sinus-borne orbital cellulitis, even if you do the drainage of the subperiosteal abscess without concurrent management of the sinusitis, there is a high likelihood of it coming back. And so oftentimes we'll go in with ENT to do the drainages if they can't reach the abscess from a medial location. And so in this particular case, it's almost impossible to apply these criteria because it's almost a different pathology.
Right, exactly. And also because our abscess was intraconal as well, and intraorbital. And so talking about one of the one of the most serious complications of orbital cellulitis is cavernous sinus thrombosis. And this is a highly fatal complication of orbital cellulitis. Before antibiotics were discovered, the death rate for cavernous sinus thrombosis associated with orbital cellulitis would be 100%. But since that started, it's decreased quite a bit, but still a decent number, about 20 to 30% mortality rate. And cavernous sinus thrombosis can happen with orbital cellulitis because of the valvulus superior and inferior ophthalmic veins, which act as access points for extension of the infection posteriorly from the facial sinuses and the orbits to the cavernous sinus. And it can also come from systemic infection, like a bloodborne infection, leading to secondary inflammatory and procoagulant responses. So you would worry about a cavernous sinus thrombosis when you have a case of orbital cellulitis with rapid progression of proptosis, ipsilateral ophthalmoplegia, because of involvement of the cranial nerves 3, 4, and 6 in the cavernous sinus. So in this diagram here, you can see cranial nerve 3 is in the superior lateral part, cranial nerve 4 is superior lateral as well, and cranial nerve 6 is just in the middle of that cavernous sinus. And this is just the left side of it. You can also have anesthesia in the V1 and V2 dermatomes, and that's because the trigeminal nerve, these two divisions run in the cavernous sinus as well, just inferior laterally here. And you can also get Horner syndrome because the sympathetic fibers run close to the CN6 as well in the cavernous sinus. Rarely you can get contralateral ophthalmoplegia, and that's because the two cavernous sinuses on each side communicate with one another. And if you get intracranial extension, you could possibly get meningitis, brain abscesses, and you could possibly get a internal carotid artery thrombosis with a stroke as well. And ultimately, this can result in death. So treatment for septic cavernous sinus thrombosis is emergent. And this emergent treatment comes in 3 main parts. The first is using IV antibiotics to treat the underlying infection. The second is anticoagulation. And for this, depending on the hospital, you may have to involve either your hematology, thrombosis, or stroke neurology team to suggest what would be the best anticoagulation for the patient. And then third, you should consult ENT as well for their opinion on whether they can drain the sinus itself and to assess whether there is any appreciable sinusitis. And so in our case, our patient didn't have any clinically significant sinusitis, and the ENT team confirmed that. But we also consulted them for help with the mastoiditis and the labyrinthitis that was incidentally found in our patient as well. And in the 3rd and 4th days of admission for this patient, we continued to monitor him, but he didn't really make any appreciable improvements in symptoms or signs. He still had a right eyelid edema and redness with moderate proptosis persisting. He didn't have any optic neuropathy, so no RIPD still, but he wasn't really clinically improving. We had a multidisciplinary meeting with most of the care teams, including rheumatology, ID, neurology, and the GenPeds team who admitted him. And we discussed the orbital inflammation here. And we all agreed that at the end, the orbital inflammation is more likely due to an infectious cause. So although we floated the idea of starting steroids in the beginning, we decided not to start it for this patient. And we repeated an MRI as well, which showed pockets of abscess continue to be intraconal. Now we saw a myositis with inflammation of the EOMs and inflammation extending to the orbital apex and the cavernous sinus as well. So,
Brian, I'll just make a comment that we also proposed, the value of a systemic workup for a hematologic spread of infection. And based on the clinical picture and the rest of the blood work, the rest of the infectious disease team didn't think it was worth kind of doing a full scan of the body. And so based on that, we kind of just did not pursue that avenue.
Right. Yeah, and Dr. Nasrallah and I were discussing this, and this was a really unique case because the risk of surgery in a case like this is really high. we have a really small abscess inside a high-risk space with important structures like the optic nerve and the globe. And the orbit is hot and inflamed, which would make visualization even more difficult. So it was really important to have a multidisciplinary team meeting here because we wanted maximum expertise from various different perspectives. And we wanted everyone to be on board before we did consider doing this high-risk surgery because there are also some medical legal implications that are involved with cases like these. We had to weigh out the risk of each choice, which included potentially blinding the kid in that eye for life with the drainage if the optic nerve was affected, versus the even larger possible risk of mortality if we didn't drain this abscess and continue to monitor. But we ultimately thought that drainage is the best option for this kid. And after reviewing the risk and benefits with the parents, they agreed. And so we stopped heparin 4 hours before the surgery and then took him to the OR for drainage. And this is a description of our surgery. Dr. Nasrallah, he hooked and tagged the lateral, superior, and medial rectus with the silk sutures. And this case was done all transconjunctivally. So they went from a transconjunctival approach via a peritomy in the superior lateral part of the conj. And then he first dissected temporally to access the temporal part of the abscess. And at this stage, it was really hard to visualize and hard to confirm that whether it was an abscess or a more vital structure like the nerve. So at this point, you have to move the globe around to see whether that abscess moves with it. And if it doesn't move, then you can confirm that it is an abscess and not the optic nerve. And so with that, we launched the initial temporal structure, but we didn't get any pus. So instead, we decided to extend this peritomy superior nasally. And then we dissected along the inferior aspect of the superior rectus. And we identified a cyst-like lesion in the posterior orbit, just superior to the optic nerve. And you can see it in that picture on the left side. So this circular structure here is the optic nerve. And just a few millimeters above that is that abscess, the hyper-enhancing part. And you can see it on this SAG scan as well. So it's quite posterior. And then when we launched the pus collection, we were able to get a small egress of purulent material. And then that was suctioned and sent for cultures. And then the child tolerated the procedure very well. And on post-op day 1, we had the initially post-op expected lid swelling and edema with proptosis. But most importantly, he didn't have any RAPD in both eyes. And this was the most critical part of the exam on post-op day 1, given the proximity of the abscess to the optic nerve. His eye pressures were quite high, and most of this was because of the swelling and edema inside the orbit, as well as the lid, and the child crying with a lot of lid manipulation during the measurement. But in this case, we just continued the cold compresses and the IV antibiotics and continued to monitor him. On post-op day 3, we did a MRI. And then as you can see here, it showed interval evacuation of the intraconal abscess. It's gotten much smaller since the drainage happened. We can see in the SAG section that there's trace fluid in the intraconal compartment of the right orbit still, just behind the globe. And this was just due to the postoperative inflammation. And this was the original abscess here, which has gotten much smaller as well. And yeah, the arrows are just pointing there. And then on follow-up on the ward over the next week and a half, the child's edema gradually improved, the orbit became less tense, and he was able to spontaneously open his eye on post-op day 3. And the ENT team on post-op day 4 decided to start him on IV prednisone for the orbital inflammation and for the labyrinthitis. And then the EOMs also improved from being severely limited on post-op day 1 to mild on post-op day 10. So just a -1 limitation, abduction and superduction there. And patient's behavior gradually returned to baseline. He became less miserable of a kid and more cooperative with our exams as well. Meanwhile, the abscess culture didn't show any growth. And the thrombosis team switched the heparin to enoxaparin on post-op week 1. And infectious disease discontinued his IV cloxacillin and metronidazole on post-op day 8. And on post-op day 11, the patient was discharged with a PICC line to continue the IV ceftriaxone for 2 months, as well as subcutaneous enoxaparin. And we arranged outpatient follow-ups with him in our clinic, thrombosis, ENT, and ID. And so the question that we were all asking ourselves throughout this whole case was, how could this have happened? This was a really rare case of orbital cellulitis with intraconal abscess and cavernous sinus thrombosis, but there wasn't any clinically significant sinusitis, and this kid didn't have any trauma. Also, concurrently, he had an ipsilateral labyrinthitis and mastoiditis. So to help us answer this question, we can review some head and neck anatomy. We think most likely in this case, although it is rare, maybe this could be from direct extension of infection of the inner ear to the orbit. So if you look at our diagram of the temporal bone here, the labyrinth and the cochlea, the inner ear structures are here around the petrous part of the temporal bone. So theoretically, this infection does have a possible route of spread to the cavernous sinus and the orbit here. And there are case reports of tumors like rhabdomyosarcoma, which originate from the temporal bone that cause an orbital apex syndrome. And there are other case series of orbital complications which happen after cochlear surgery as well. So given that there's a potential route here, we think this is our most likely rationale for this abscess at this time. One other theory that we discuss, probably even less likely, but possible given the anatomy, is that the orbital involvement could have come from a septic thrombophlebitis, which started in the area of the labyrinth and tracks retrograde to the orbit. And this is because the cavernous sinus and the vestibular system both share the inferior petrosal sinus as an area of drainage. And because these sinuses are valveless, blood could theoretically flow in either direction along a pressure gradient. But the most difficult part of this explanation is that it's hard to explain how an abscess came from this into the orbit. So less likely explanation, but if anyone has any ideas that they could share on how this abscess came to play, we'd be happy to hear that as well. And so take-home points for this grand rounds are a differential for orbital conditions. So hopefully you can have some differentials if you get an atypical case of orbital cellulitis, and that you can recognize it as a life-threatening condition, which has a low threshold to image and start antibiotics. Hopefully you can recognize that the different serious complications that can arise from orbital cellulitis, such as subperiosteal orbital abscesses or cavernous sinus thrombosis, and the importance of interdisciplinary management of orbital cellulitis with cavernous sinus thrombosis, including involvement from ENT, peds if it's a child, and the thrombosis or the stroke neurology teams. So with that, I thank you for your attention, and thank you to the oculoplastics and pediatric ophthalmology fellows involved with this case as well, Drs. Kenny Chang, Mary Leeds Dersh, Ben Host, and Tiffany Ma, and to Dr. Nasrallah for leading this case, and to all the pediatric ophthalmology staff who also helped to oversee this case at SickKids. Yeah,
well, fascinating case, Brian. Thank you. There's a couple questions in the chat. I think you guys confirmed that there was no growth. And the second question from Dr. Eon was, how did you rule out a dental source?
So that was mostly based off of the imaging, mostly based off of the CT and MRI. So I think in the interest of time, we'll probably move on to Mohaned's case and get going on that one.
Yeah. You see my slides? Okay.
Yes.
So
yeah.
Mohaned, one of the PGY3s in the program, and for today we're going to talk about evisceration, enucleation, and sympathetic ophthalmia prevention. And the objectives that we thought about talking is review of the historical perspective in sympathetic ophthalmia, review recent updates in the incidence and risk of sympathetic ophthalmia, and discuss the considerations prior to enucleation and evisceration. We will start by presenting the first case, who is a 75-year-old man who sustained an open globe injury to his right eye after he tripped and fell on a nightstand. He had a globe repair and his pain has improved over the past 2 days. His post-op vision is light perception and his IOP was 6. He remembered discussions about the risk of losing his fellow eye after this traumatic injury and asks about the exact risk. And here is our first poll. What is the estimated risk of sympathetic ophthalmia due to traumatic injuries? It's 1 in 100, 1 in 1,000, 1 in 2,000, 1 in 20,000, 1 in 50,000.
Thanks, Mohammed. We'll give that just a second to run. And for some folks, we might have needed option F. It doesn't exist. I'm sure we'll get some comments about that. But here's your results.
Okay. Our second poll for the case is, what is the estimated risk of sympathetic ophthalmia due to intraocular surgery? And the answer choice or the options are the same: 1 in 100, 1 in 1,000, 1 in 2,000, 1 in 20,000, and 1 in 50,000.
We'll end that there, but it seems that the audience thinks that's less risky.
Okay. We're going to go back and hopefully address these points. Now, the second case that we want to present is a 92-year-old lady who had a corneal melting and perforation from a corneal ulcer. She was treated conservatively and her pain largely subsided. Her vision is no NLP or no light perception with intermittent agonizing pain. Her IOP is 15 and she's been referred for eye removal. And our poll question is, what percentage of patients continue to have pain? 100%, 80%, 66%, and 30%. And the pain here refers to after enucleation or evisceration. Okay. Now, we want to start off our talk by presenting this major review, which was published in the 1989, and their therapy and prognosis section, they made this statement, which is the only known prevention for sympathetic ophthalmia is enucleation, and to prevent the disease, it must be performed prior to the development of the autoimmune response. And our question was, is this true? If we go back to see how did all of this start, we can see that, or we can find that in the 1880s, a Scottish ophthalmologist named James Wardrope, who had considerable knowledge in horses as well, wrote in one of the chapters he authored a not infrequent inflammation in the eye of the horse that usually affects one eye and then the other, almost always sooner or later destroying vision. And the treatment for that condition at that time was to incise the cornea and help prolapse the intraocular contents. After that, the ophthalmologist that first coined the term sympathetic ophthalmia, which was before the invention of the ophthalmoscope, he wrote a statement saying, why should we hesitate to lay open an eye in which vision is extinguished if the operation affords a reasonable hope to save the other? And after that, British surgeon Dr. Burchard reported the first successful removal of a blind painful eye following an iron foreign body material that was never extracted. And after that, the pain got better and the inflammation in the other eye settled.
Now that's interesting, Mohammed, because it's usually thought that you have to complete the enucleation before there's involvement of the other eye. So that's an interesting tidbit there.
Amandeep, it's almost like there are a lot of anecdotes.
And after that, in the 1860s, this doctor then made the observation that once the inflammation has kicked in, it is ineffective to remove the eye, and suggested that the only way to prevent it is to remove the eye after the vision has been lost. And after that, many reports came suggesting again that you have to take the eye out within the 14 days period of the injury, because the initial thought, sympathetic ophthalmia does not occur before 14 days. But with time, cases reported that this can occur also within that time period. And if we go back and look, the historical evidence was merely based on clinical observation and speculation, and the practice of prophylactically enucleating or enucleating the eye of enucleating the injured eye was the treatment, mainly due to lack of other ways of treating other to what we have today. An interesting fact that we found is that the practice of prophylactic removing an eye was based on horses' eyes, and Dr. James Wadrow observed that initially from horses' eyes. And as time gone by and knowledge accumulated, the disease that he thought was sympathetic ophthalmia is actually called equine recurrent uveitis. And this came to knowledge because when they did ocular specimen examination of the ocular specimens, they did not find any resemblance between that disease and sympathetic ophthalmia. And some of the reports, they say like sympathetic ophthalmia does not exist in other species. The other question that we want to ask is how common is it, or is it common? And one of the earliest review articles gathered the incidence rate or the reported rate of sympathetic ophthalmia in the literature due to traumatic injury. And we can see here from the 1800s to the late 1900s, the rate ranged from 0 to 12%, 2%, 1%, 0.5%. And more recently, in 1979, this article reviewed the literature and reported the incidence of sympathetic ophthalmia after penetrating injury to be between 0.2% to 0.5%, and for after intraocular surgery was 0.1%. Also, further studies and meta-analyses were done, some of which were done by Dr. Edsel Ng. He looked at all of the patients that were reported to have open globe injuries, and after that developed sympathetic ophthalmia. And the number that he found was 0.25%. And the incidence rate of sympathetic ophthalmia was 33 individual per 100,000. Another systematic review that he did on sympathetic ophthalmia and intraocular surgery, the number was even less. It was 0.06%. And the incidence rate was 9.24 per 100,000. Another systematic review and meta-analysis compiling around 7,000 patients, the rate or the estimated rate of sympathetic ophthalmia was found to be 0.12%. And then another study which did different kind of mean of trying to estimate the numbers of sympathetic ophthalmia. They did a prospective surveillance of ophthalmologists in UK and Ireland, and they got the report once they faced a patient who was diagnosed with sympathetic ophthalmia, and after that they calculated the estimated incidence, and the number that they got to was 0.03 per 100,000 patients. And when we look at those numbers, we say, okay, compared to the idiopathic uveitis, how common is it? The numbers in the literature, the overall incidence rate of idiopathic uveitis is 24 cases per 100,000, which seemed a little bit odd because we know that, or the idea is that sympathetic ophthalmia is much rarer than this, but the number that we have today, or most of the numbers that we have today, indicating that it's slightly higher. One possible explanation, when we looked at the dose report and meta-analyses, we found there is no clear definition of sympathetic ophthalmia, and there may be an overestimation of the uveitis being called as sympathetic ophthalmia due to presence of ocular injury in the past. Another question we wanted to answer, because all of the historical reports did this procedure to reduce the risk and to see if it's going to help it disappear. And we know from studies that sympathetic ophthalmia, we know that enucleation of the inciting eye does not lead to any improvement in the visual outcome or reduces the need for medical therapy. And in this meta-analysis, the authors concluded that based on the available data, no evidence exists that primary enucleation or evisceration reduces the risk of secondary sympathetic ophthalmia. Another point of controversy in the literature we found is that there's a lot of discussion about sympathetic ophthalmia being after evisceration compared to enucleation. And the controversy emerged in the 1960s and 1970s after a few authors reported cases of sympathetic ophthalmia after they did eviscerations for their patients. But again, after years gone by and cases being accumulated in the literature, the review of those cases did not find or did not identify sympathetic ophthalmia after evisceration. And this NICE review, in the end, the author stated, careful review of the available data simply does not allow for a definitive conclusion. On the topic of comparison and fear about sympathetic ophthalmia, we always educate the patients about the risk of losing the eye due to the inflammation that that may happen after injury. We wanted to compare the numbers between post-cataract endophthalmitis and the rate of sympathetic ophthalmia, and we know that the risk of post-cataract endophthalmitis, depending on the risk factors, is ranging between 0.01 to 0.1%. And for sympathetic ophthalmia, for the studies that we reviewed, the incidence rate was around 0.12% to 0.25%. And we know that...
I'll just make the comment that also the rate of sympathetic ophthalmia from recent studies shows that post-surgical sympathetic ophthalmia, the rate seems to be similar to the rate of endophthalmitis in the operated eye. So it'd be interesting to see how many people have had endophthalmitis in their career and how many of them have had sympathetic ophthalmia in the same population of surgical patients, because the numbers should be relatively similar based on the reports.
And we know now that we have treatments for this blinding disease, which is very different than at the time that all of this has started. And we know as well that enucleation and evisceration does not change the outcome. Other points of consideration when there's a referral for eye removal, the residual vision, even if the vision is very poor, hand motion vision or lack perception vision, this can be very useful for navigational purposes if for unfortunate reason or another, the good eye was lost. Another reason or another consideration we keep in mind is that the ocular motility of the normal eye is better than any prosthetic eye. And the literature reported that eviscerated eyes and implants, they have around 70% of normal motility, and the number is even less for those who underwent enucleation. The perception of self-disfigurement with the prosthesis was also reported among patients who had eye removal. There is the phantom eye pain, which is similar to what we all know as like phantom limb pain. And the more drastic, there is more drastic change in quality of life and a wider array of psychosocial difficulties that patients experience once they undergo eye removal surgery. For the phantom eye pain, around 1/3 of the patients continue to have pain after an eye amputation, and nearly 1/4 of patients complain of phantom eye pain. And this is an enucleation or evisceration in general indication. It's not only for the traumatic indications or for those who had severe globe distortion. And the phantom eye pain, it can be every day. 30% of them experiences every day, 15% around several times a week, 18% one time a week, and 36% at least once a week. The last thing we want to note is the quality of life is definitely different. Depression was noted to be more in those patients, the perception of altered body image, lower self-esteem, a loss of self-confidence, and reaching to the point that patients may fear of meeting new people due to the presence of the prosthetic eye or the self-perception after their eye was removed. And I'll leave the final remarks for Dr. Nasrallah. Thank you all for listening.
Thanks, Mohammed. Thank you very much for that presentation. Just wanted to make a quick few remarks and then we'll open for questions before the end of the session. The main thing I wanted to say is that it's one of these topics that we're all we learn about in residency, and the feeling about doing enucleations and eviscerations to prevent sympathetic ophthalmia among the oculoplastic community has really, really kind of gone out of favor over the last several years. And so we're not very keen on removing eyes for the sake of sympathetic ophthalmia prevention. And so I think it's always an important consideration to have. And every clinical situation is different. But one thing I would kind of hope to convey, and this is often done in the best of spirits, but not to kind of prime the patient that the eye needs to be removed, especially after a globe repair that's relatively successful. If the patient has had a globe repair that's relatively successful, the pressure's fine. I don't think that they need to be primed that their eye needs to be removed. I think that's a discussion to have at a later date, if at all. And I think the other thing to note is, if a globe repair is done and the patient has a lot of pain on post-operative day one, that's not what we mean by a blind, painful eye. They just had surgery. I think it's important to give the eye time to recover and have that pain potentially dissipate before immediately sending for an enucleation or evisceration to prevent sympathetic ophthalmia because they have post-op day one pain, especially if like the corneal sutures weren't buried and their pain is very superficial, ocular surface. Anyway, I'll open the floor for questions.
Great point, George and Mohammed. I think we don't often fully account for the psychological impact of these types of injuries on our patients. And I think that last slide you had, Mohammed, was quite important. This really can, and I've seen it can have significant impact on a patient's quality of life and their self-esteem. I do have a question for you guys. In terms of post-surgery risk of sympathetic ophthalmia, does it matter what type of intraocular procedure they had, whether it was a phaco or a trab or a vitrectomy, for example?
Yeah. So most of the reports that have commented on that have said that, yes, there is a difference based on the surgery, with the highest rate being after vitrectomy. A lot of those reports were done at a time when the technology was such that the gauge for the vitrectomy was higher and it was different technology. How that relates to today's risk with today's vitrectomy technology with smaller gauge needles and whatnot is hard to extrapolate. Again, that's on the backdrop of people questioning whether sympathetic ophthalmia even exists, right? Emily, if you're muted, the other comment I wanted to make, and Mohammed kind of touched on it, is that a lot of these studies, the retrospective studies or the population studies looking at assessing the rate and risk of sympathetic ophthalmia, don't always lay out a clear diagnostic criteria for sympathetic ophthalmia, and it's relatively open-ended. And while we know that sympathetic ophthalmia classically presents as a sort of similar to VKH style presentation, we're not sure that all of those studies account for only those cases. And so it's very possible that cases of otherwise idiopathic uveitis are classified as sympathetic ophthalmia simply because the definition is a uveitis after a trauma to the other eye. But that's kind of an important bias to consider.
Great point. Great point. We don't have any further questions in the chat, so I do want to thank Mohammed and Brian for wonderful talks this morning. Very practical. These are conversations and difficult cases that all of us encounter when on call. And it's nice to get a review of both sympathetic, but also preseptal/orbital cellulitis in a child. I think that's always a concerning presentation for any of us. So I do appreciate you guys taking the time to review that. I did just put the evaluation link in the chat. I'm sorry I was a little late, so I will keep the meeting running for those who haven't had a chance to complete the evaluation. But thank you, Dr. Nasrallah, as well for supervising today's rounds. And I look forward to seeing you guys all next week, where we have Francesco Pici, who's a new recruit to the university, a uveitis specialist. I think he's going to be just as interesting as these guys. So I do look forward to seeing you guys next week. Bye.